Documentation is something that is often overlooked in EMS education, but is really one of the most important things that you can learn. And like any other skill, it takes practice to make perfect. Here are your objectives for documentation. One of the things that I often get asked are, do I need all this information all the time? And the answer is no. You won't need all the information in every single run and every single PCR. In some incidences, the information will help you document what happened, and other times you may need only a small portion of the information that you've obtained to complete your PCR or your documentation. You have to think of documentation as a story. For your story to make sense, you don't need to leave anything out. And just like a story, a report needs to have a logical beginning and a logical conclusion. The meat of the matter is in the middle. You have to make sure that it makes sense to the one that's writing the report, as well as the one that will be reading the report, as well as anybody who's reviewing the scene and the report. In other words, lawyers, law enforcement, court, things like that. The beginning of your story is going to outline your basic facts that initiated the response of your emergency vehicles, why you were sent to this location, when the event took place, who was involved, where it happened, what took place prior to your arrival, so the who, what, where, when, why. Okay? Basically, all documentation must include why you were called and the needs of the patient. There's a couple of different ways that you can document, but whichever category or mode or method that you use to document, those questions need to be answered. The next area that is necessary to documentation are your baseline facts, the vital signs. The baseline vitals tell you and whoever's reading it at what level you found your patient. Were they hypotensive, hypertensive, bradycardic, apneic, tachycardic? The vital signs can be used later kind of as an indicator to what direction your patient's going. Are they getting better? Are they maintaining? Are they getting worse? From here, we're going to make sure that we're documenting all your procedures, every last one of your procedures performed, and the result of that procedure. That area, along with your assessment of your patient, is some of the most critical components from a legal standpoint. Every recognized problem must be documented and treated appropriately, and documented that it was treated appropriately. All right. Remember that both positive and negative findings must be documented. For example, with chest pain, if they have nausea or vomiting, or if they don't have nausea or vomiting. Okay, so an example, you place a pressure dressing on the distal aspect of the right forearm on your patient to slow the bleeding without losing the pulse. Okay, standard bleeding control. After a few minutes, the patient tells you they have a tingling sensation in the fingers on that same arm. So you know that, it's too tight, we need to loosen the dressing. So you document that the patient had the tingling sensation, you loosened the document without an increase in bleeding, the pulse is still present, and sensation is now back to that region. You've assessed, treated, reassessed, treated, and documented what was done and what was found each time. Your sections of your PCR, whether it be on paper or with any kind of, whether it be on paper or on electronic format, have several different sections that are going to generally be the same. So you're going to have your administrative section. This is going to be things like your EMS unit number, the crew names, times, key times for the call, such as dispatch time, arrived on scene, departed the scene, arrived at destination, etc. And it will also have the address of where you responded to. Your next section is going to be your patient demographics. This is name, age, gender, date of birth, social, address, where they were found, insurance billing information, and sometimes even any care provided before EMS arrival. Your vital signs are going to be things, of course, like your pulse, respirations, blood pressure, any other things like that. Make sure that you have 2 sets of vital signs for every patient, because you have to have a baseline and you have to have a reassessment. Otherwise, you are not doing a complete assessment of that patient. Now, when you actually get to the narrative portion, the patient care narrative, this is a written account of the entire call. There's several different standard formats that you can follow, and whichever agency, some agencies require certain formats and others let you pick whatever format. But once you find one that feels more comfortable for you and feels more natural to write in, try to stick with it if at all possible. And additionally, you also need to make sure Some PCRs may have a separate area for treatment and assessments, and others may include it in your narrative, but make sure that you do write down and document any and all treatments and reassessments that you've done, as well as the actual assessments that you've done. Now, one of the main charting methods that we'll talk about is SOAP, and this breaks down into 4 areas. So for your narrative, now all the other stuff is still the same, but your narrative itself is written as subjective. So this is information that is subjective as it's given by the patient: complaint, history, present illness, symptoms, things that we can't necessarily see, such as difficulty breathing. Your objective is going to be information that's observed, such as vital signs, pupillary reaction, response to pain, things that we can measure or we can see or feel. Okay? Your assessment, this is your field impression of the patient based on the subjective and the objective. So basically your treatment plan, what you think is going to happen. And then your plan is the treatment that's provided and any transport information. So this is what you do to the patient, as well as any response to those treatments or what you did to the patient. This is not my particular favorite, but some people do really like it. Now, chart is another major format, and this one usually is going to start with some sort of introductory statement, such as, 36-year-old male found lying on sofa unresponsive to pain, or whatever, basically however you found the patient. Then you've got your chief complaint, and this is what is going to be why you're there, what happened, why are they calling 911. All right, your history is a history of present illness, as well as any pertinent past medical history. So how long this chest pain's been going on, and the fact that he's had 2 bypasses and 3 grafts and 2 stents. All of that would be your current and past pertinent. And then your assessment is any information from your primary or your secondary assessments and your reassessment. So this is what you find when you get to the patient and during your assessment. Your RX or treatment is what treatments you do and their responses to them. And transport is where and how they were transported, any changes during transport, and transfer of care. So this would be like patient transported non-emergency to East Alabama Medical Center without any changes in condition. At destination, patient moved over to ER bed, report given to RN. Patient care turned over. Something like that. And then the last form that we're going to talk about is cheated, which is kind of similar to chart, but just a little bit variant. You usually will start with a statement at the beginning, and then you'll have your chief complaint, then you'll have your history, same stuff as last time. You'll have your exam, so this is all your primary and secondary assessments, and then the assessment here is field impression based on the first 3 sections. Then you've got your treatment, and then disposition, which is your transport and care. I use kind of a combination of chart and cheated, somewhere kind of a conglomeration there of the 2. Now for your legal concerns, we know PCR are legal and medical records protected by HIPAA. They can make you or they can break you. So it's very important that you treat them like the legal documents that they are. If you need to correct an error on a written PCR, draw 1 line through it. Initial it, write the correct information. Don't scribble it out, white it out, or anything like that. Now, of course, if you're on a computer, just backspace and then type what you needed to type. Whoever completes the form is going to go to court with it if it ever needs to go. You want to make sure that your information is objective and subjective, and make sure that your information is clear and that there's no other possibility of drawing conclusions from what you said, so that they don't draw the wrong conclusion. You want to present facts. Now, your functions of your PCR, like we said, legal medical record of care. They provide for your continuity of care to make sure that the nurses at the ER know that you've given 3 doses of Epi already, or 3 doses of Narcan, or whatever you've given. Make sure that they don't duplicate things unnecessarily, but also to make sure that there's not any problems with what they may do in the future that would contradict things that, or be contradicted because of things that you've already done. As far as educational, these can be used to just demonstrate proper documentation and how to handle unusual or uncommon cases in certain circumstances. Your administrative side is going to be more of like statistics or billing, so that the billing office can send and obtain payment for the services rendered. It's used in research. Usually this is more of a retrospective research where they go back and pull PCRs and look and see, okay, this many people had heart attacks, this many people survived, and these many people out of those had intubations versus supraglottic. So they're just looking to see what can we do, maybe some changes in the future that might improve survival or decrease problems. And then evaluation and QA, QI, quality improvement and quality assurance. And this is just making sure that we're doing what we're supposed to do correctly, that we're documenting correctly, that we are providing the appropriate care and following our protocols and doing everything that we need to be doing. There are a couple of special reporting situations I want to make sure that you are familiar with. So your critical elements, these are things that can really cause you some problems if not documented correctly. So for IV therapy, some things that you want to include in your documentation of that skill would be things like aseptic technique, that you used clean technique essentially. The venipuncture site, so did you start the IV in the back of the left arm? Did you start it in the left forearm? Did you start it in the right AC? Where did you start that IV? What IV set was used? 10 drop, 15 drop, 60 drop? 20 drop? What type of fluid? Was it lactated ringers? Was it normal saline? Was it D5W? Who did it? Who performed the skill? The evaluation at the site destination so that it was still good, essentially it had not infiltrated before you turned over care. That's important too. Initiation time, what time the IV was started. All skills need to have a time associated with them. What catheter sized? 14, 16, 18, 20, 22, 24? How many attempts? It's okay if the first attempt doesn't work. You may need to take 2 or 3 attempts, but make sure that you document that you had 3 attempts to get a successful IV. And then your infusion rate and total amount of fluids infused. Any complications? Sometimes veins blow, and that happens, and that's okay. What's not okay is for you to ignore it and pretend it didn't happen. You need to document that it occurred and what you did about it, such as removing that, stopping the flow, removing that IV catheter, and putting direct pressure and a bandage, sterile bandage, over that site. Now, your next one is your medication administration. You want to make sure that you're documenting any medications administered before EMS arrival. We want to make sure that we performed an allergy check and the results of that allergy check. We want to make sure that we include the name of the medication, the route of the administration, who administered it, the source of the medical authorization, such as medical director, or is this a protocol? Did you call and get permission? However you got the authorization. We want to make sure we document administration times. We make sure that we document the dose and the units. So if we're giving Benadryl, 25 to 50 milligrams is your standard dose here. So we would make sure that we say if we're given 50 milligrams that we document that we give 50 milligrams of diphenhydramine. And then we want to make sure that we document the patient response. Now sometimes there is no response. It just doesn't do anything to the patient at all, and that's okay. But you need to make sure that you document that happens. If they have a bad reaction to it, sometimes that happens. Document it. If they get better, if they have pain, you give nitrous oxide and they feel better, document it. And then your last critical element, or that we'll talk about right now, is your airway management. So for these, you want to make sure that you're documenting what that airway procedure was, the time of the procedure, what equipment was used. So for instance, did we use a supraglottic king? Did we use an LMA? Did we use a CPAP? Whatever the equipment is that was used, and the size. We want to make sure that we document the number of attempts. We want to make sure that we are documenting that it was successful. We want to make sure that we document the responses to it, who did it, any adjuncts used, OPA, NPA, salt airways, things like that, any potential complications, and confirmation of this airway. So we want to make sure we're recording to tell how and when it was confirmed, such as confirmed with bilateral auscultation, negative breath sounds over the epigastrum after moving to the stretcher, after loading into the ambulance, lung breath sounds confirmed again bilaterally. Secondary confirmation with capnography, getting a capnography reading of 35. So something to let you know that you have in fact confirmed that that airway is still valid. All right, and then at destination, confirmation. Make sure that it is still good when you get there. As far as your accusations of incompetence, a well-documented PCR is probably your biggest defense against this. If you don't document it, it didn't happen. Everybody knows that. But if you don't document it well, then it opens up a world of liability and questions that can come up in court, and that's something you really don't want to do or have to deal with. So make sure that however you are writing your PCR, that you are presenting a crystal clear picture of what happened and all of the things that you did or did not do, as well as why you did or did not do. For your patient refusals, this one can be a rather tricky situation as well. Competent adults have the right to refuse treatment, and that's really important. So if they don't want us to treat them and they're competent, we can't make them let us treat them or help them. Like a doctor told me once, you've got the right to be stupid. So before you leave the scene, try again to persuade the patient to go to the hospital. All right? Make sure that the patient's able to make a rational, informed decision. Inform the patient why they need to go and what might happen to them if they don't go, like loss of limb, life, things like that. Consult medical direction if needed, whatever your protocols say. And if the patient still refuses, document any assessments and then have a family member, police officer, or bystander, in that order, sign the form verifying that they refused to go. All right? And we want to have the patient sign the refusal. Now, if the patient refuses to sign the refusal, have that same family member, police officer, bystander sign that they, just attesting to that they refused to sign the paper. And then complete your pre-hospital care report. Complete the assessment. If they refused care or did not allow for a complete assessment, document that they did not allow for a proper assessment, and document whatever assessments were completed, such as things that you can observe without touching them or without them going any further into it, like the fact that they were red or they were very pale or whatever that you could observe. Okay, document any care that you wanted to provide for the patient, and that you explain to them the possible consequences to a failure to accept that care, including potential death. And then offer alternative methods of gaining care, such as going to their doctor or to urgent care or to the ER by themselves. And then always state that you had a willingness to return, that you stated to tell them, or that you told them to call back 911 if something happens, if they change their mind. And that should give you kind of a safety net, if you will. Psychiatric incidences can be some of the most difficult to deal with, but also to document. Because your signs and symptoms are much less defined on the psychiatric level, this can put you as a provider into kind of a hazardous, precarious situation. So we want to make sure that we are, as much as we can, we are performing a good physical exam of a psychiatric patient. We want to make sure that we're performing these exams with caution for your own personal safety. Make sure anything involving like a chest exam with a female patient has a female healthcare provider. Anytime you need to examine genitalia, you have the same-sex provider helping. If you're unable to do your assessment, the examination may need to be postponed until that patient can be calmed down, and that's okay. Document that. For your suicidal thoughts, destructive behavior, or aggressive behaviors, those need to be documented as the incident progresses. Okay. Ideally, the documentation should specify how the incident progressed in chronological order. If you need to use restraints, make sure that you first establish the need for the use of restraints, why you needed to physically restrain them or chemically restrain them as you progress on in your education. Once it's clear that you have adequate personnel, enough support personnel on hand to control the patient, you need to document how the restraints were applied and the reassessment after the restraints. If there's drug involvement, document the types of drugs ingested and proceed accordingly. For your MCIs, you may not have ton of time to fill out the complete the report or the form before the next call, so you may need to fill it out at a later date and time. Most local MCI plans have some means of recording your important information kind of on a temporary basis until you can get everything completed. And the standard for completing these forms in an MCI is not going to be the same standard that you are going to have for your typical calls.